Kanski lecture series, and this is going to be the hereditary fundus dystrophies part 5. And in this part, we are going to discuss about the macular dystrophies, basically the Best disease. So, Best Whittley-form macular dystrophy. Introduction. The Best Whittley-form macular dystrophy, early or juvenile onset Whittley-form macular dystrophy, is the second most common macular dystrophy after the Stargardt disease. It is due to the allelic variation in the bestrophin gene on chromosome 11q13. So basically it is the disorder of the macula, and it is the early or juvenile onset, and it is the second most common macular dystrophy. The first is being the Stargardt disease, and there is a variation in the best1 gene, and which is basically present on chromosome 11. Bestrophin is found on the plasma membrane of the RPE and the function as transmembrane ion channel. Inheritance is autosomal dominant with variable penetrance and expressivity. The prognosis is usually reasonably good until middle age, after which the visual acuity declines in one or both eyes due to CNV scarring and geographic atrophy. So basically vision decline due to the complications associated with the Best disease. So there are diagnosis. How do you diagnose it? Science, there is a gradual evolution through the following stages. So there are pre-Whittley-form stage, then there is a Whittley-form stage, then there is a pseudo-hypopion, and the Whitley eruptive stage, and then there is a atrophic stage. So just remember the name sunny side up appearance of the macula in a case of a Whitley form. So pre-Whitley form is characterized by a subnormal EOG in an asymptomatic infant or child with the normal fundus. So in the pre-Whitley form stage, there is a normal fundus appearance, but the EOG will be abnormal. Then there is a Whitley form, develops in an infancy or early childhood and does not usually impair vision. A round or sharply delineated sunny side up egg yolk macular lesion between the half a disc or a 2 disc diameter in size develop within the RPE. So the size is between the half of the disc to the 2 disc diameter, and basically it develops in the RPE. The size of the lesion and the stage of the development in the two eyes may be asymmetrical, and sometimes only one eye is involved initially. Occasionally, condition may be extramacular and multiple. Pseudohypopion may occur when the part of the lesion regresses, often at puberty. So, pseudohypopion is basically when the only the small part of the egg yolk is being left. It is known as a pseudohypopion. Then there is a Whitley eruptive stage. The lesion breaks up and visual acuity drops. Atrophic, in which all the pigments has disappeared, leaving an atrophic area of RPE. So let's see figure 15.24. So you can see this is a Best dystrophy. A is showing us a Whitley form stage. B is showing us an FAF image of the pseudohypopion. So there is a pseudohypopion. C is showing us a Whitley eruptive stage. So the lesion is breakdown. D is showing F showing central hypofluorescence. E is showing OCT image of the eye. In P in the Whitley form stage showing subretinal hyporeflective component. So there is a hyporeflective component here. So how do you investigate the disease? So FAF, fundus autofluorescence, the yellowish material is intensely hyper-autofluorescent. In the later atrophic stage, hypo-autofluorescent area supervenes. So in a case of active disease, it is hyper-autofluorescence, and in a case of atrophic, it is hypo-autofluorescent area. Then FA fundus angiography show corresponding hypofluorescence due to masking. OCT show material beneath, above, and within the RPE. EOG is severely subnormal during all stages, Arden index less than 1.5, and is abnormal in carriers with clinically normal fundus, and it is even abnormal in the clinically normal fundus as well in a case of an carriers. So then there is a multifocal Whittley-form lesion without Best disease. So basically such disease occur in the adulthood. So occasionally multifocal Whittley-form lesion identical to those seen in Best dystrophy but distributed around the macular vascular arcade and optic disc, but may manifest in adult life and give rise to a diagnostic problem. However, in these patients the EOG is normal and the family history is negative. So EOG is normal and family history is negative. and mostly in the adult life. Occasionally, genetically confirmed Best dystrophy may present with multifocal lesion. The relationship between the multifocal vitiliform lesion, juvenile vitiliform Best dystrophy, and adult onset vitiliform macular dystrophy is incompletely defined, although some cases of each are associated with mutation in the same gene. So this is a multiform vitiliform lesion without Best disease. So you can see multiple lesions around the arcades. Then there is an adult onset vitiliform macular dystrophy, when symmetrical yellow deposits that resemble Best disease develop in the macula of older individuals. So this was around the macula but not involving the macula, but adult onset is involving the macula but in the older individuals. The term adult onset vitiliform macular foveomacular dystrophy is used. In contrast to juvenile Best disease, the foveal lesions are often smaller. There is a genetic heterogeneity, including mutation in the PRPH2, IMPG2 are the best one gene. Vitiliform macular lesions may also be observed in a wide range of other conditions, including acute idiopathic exudative polymorphous vitiliform maculopathy and acute laser damage. This appearance may occur secondary to basal lamellar drusen, reticular pseudotrusion, and chronic vitreomacular traction. So there can be mutation in the PRPH2 gene, IMPG2 gene, and BEST1 gene as well. And the vitiliform macular lesion gives similar findings as acute idiopathic exudative polymorphous vitiliform maculopathy and acute laser damage. And this appearance may occur secondary to, like, if there is a basal lamellar drusen, there is a reticular pseudodrusen, and chronic vitreomacular traction. Adult onset vitiliform macular dystrophy may also be grouped in the phenotypical spectrum of pattern dystrophy. So, symptoms are often that the condition is discovered by chance but may present in the late, middle, or old age with decreased central vision. So, it presents in an old or middle age with a decreased central vision. The vision is often reduced by one or more lines at presentation, and mild deterioration occurs subsequently. The prognosis varies from case to case. So, a signs consist of a round or oval, slightly elevated, yellowish subfoveal deposits, generally smaller than the lesion of the Best disease seen in one or both eyes. So, there will be the round and oval yellowish subfoveal deposit, and it will be less in diameter as compared to Best disease. There may be central pigmentation, and numerous associated drusens are present. In some cases, the material may persist, absorb, or break up and disperse at a late stage, leaving atrophy of a variable severity. Choroidal neovascularization sometimes supervene. Investigations. OCT show hyperreflective material associated with RPE similar to Best disease and C. So you can see this is a uh, showing us an image of the adult onset vitiliform dystrophy. So you can see the yellowish round lesion around the fovea, and B is showing FA corresponding to hyperfluorescence, and C is showing FAF of a different patient showing vitiliform lesion in the inferior macula arrowhead, and RPE atrophy arrow. So this hyperfluorescent area is giving us a vitiliform lesion, and hypofluorescent is atrophy. And this is OCT showing the RPE atrophy. This is showing arrow, and arrowhead is showing the subretinal material. So OCT show hyperreflective material associated with RPE similar to Best disease. FAF imaging show intense hyperautofluorescence corresponding to the deposited material, which is typically much more obvious than on clinical examination. When atrophy supervenes, this is hypoautofluorescence. So the active lesion will be hyper and the atrophy will be hypo. Fluorescent angiography is almost never needed but can occasionally be useful to show absence of neovascularization. In the adult onset vitiliform macular dystrophy, FIT typically shows central hypofluorescence surrounding by a small irregular hyperfluorescent ring. In the late phase, the entire lesions show the hyperfluorescence. So there will be the central hypofluorescence and the surrounding area will hyperfluorescent, but after a late phase, the entire lesion will become hyperfluorescence. Then there is a pattern dystrophy of the retinal pigment epithelium. So pattern or patterned dystrophy of RPE encompasses several clinical appearances associated with the accumulation of the lipofuscin at the level of RPE and manifesting with the yellow, whitish or gray or pigment deposit at the macula in a variety of appearance. The most common presenting symptoms is a reduced visual acuity or mild metamorphosia in early adulthood or later, but many are asymptomatic. So basically, there is an accumulation of the lipofuscin at the level of the RPE, and the most common presenting symptoms is reduced visual acuity or mild metaphoria in early adulthood or later, but many are asymptomatic. So some patients are asymptomatic, some are having a reduced visual acuity, and there is going to be the distortion of image in the early adulthood. The described entities have been associated with a variety of gene and different mode of inheritance. ERG may show normal or reduced responses. So ERG can be normal or show reduced responses. The different clinical appearances are believed in many cases to represent a variable expression of a mutation in the PRPH2. So there is a mutation in the PRPH2 gene. Other genes and conditions can give rise to similar appearance, and notably a pattern dystrophy-like appearance can occur in response to a range of a pathogenic stimuli. So basically, there are certain kinds of patterns that are being present in the retina that is being associated with pattern dystrophy of the retinal pigment epithelium. So if it is a butterfly shape, so foveal yellow and melanin pigmentation commonly in a spoke like or butterfly wing like conformation. So there will be the like a spoke like or butterfly wing type presentation in the fovea. Drusen's or Stargardt like flecks may be associated with any pattern dystrophy. FA shows central and radiating hypofluorescence with surrounding hyperfluorescence. So there will be the surrounding hypofluorescence and there is a surrounding hyperfluorescence. So let's see figure 15.27. So this is a butterfly shape pattern dystrophy of RPE. A is showing spokes of a yellowish material and pigment radiating from foveola. So spokes like wheel pattern, and B is associated. So there is a flex that are being associated, and C is showing FA of the eye, and A showing central uh, hypofluorescence, and there is a surrounding hyperfluorescence. Next is a reticular jogren, a network of pigmented lines at the posterior pole. Then there is a multifocal pattern dystrophy stimulating fundus flavi maculatus, just like a Stargardt disease. Multiple widely scattered irregular yellowish lesion which may be similar to those seen in fundus flavi maculatus. FA show hyperfluorescence of the fleck, and the choroid is not dark. So the difference is basically in the FA. The FA will show hyperfluorescence of the fleck and the choroid is not dark. So let's see figure 15.28. So this is a multifocal pattern dystrophy stimulating fundus flavi maculatus. So there is like a flex like appearance. So there is a hyperfluorescence but the choroid is not dark. Then there is a macro-reticular spider shape. Initially, pigment granules are seen at the fovea. Reticular pigmentation develops that separate to periphery. So this is a figure for 15.29 showing fluorescent angiography of the macro-retinal pattern dystrophy. So there is a hyperfluorescent and hypofluorescent areas in between. Then there is a adult onset vitelliform. Then there is a fundus pulvirulentus is extremely rare macular pigment mottling develops. Then there is a North Carolina macular dystrophy. North Carolina macular dystrophy is a rare non-progressive condition. It was first described in families living in mountain of North Carolina. So it is a geographical based dystrophy, and subsequently in many unrelated families in other part of the world. Inheritance is autosomal dominant with complete penetrance but highly variable expressivity. So there are different grades, grade 1, 2 and 3. Grade 1 is characterized by the yellowish white drusen like peripheral and macular deposits that develop during the first decade but may remain asymptomatic throughout life. So in there is a drusens at the periphery, but the patient is usually asymptomatic throughout the life. Grade 2 is characterized by the deep confluent macular deposits. The long-term visual prognosis is guarded because some patients develop neovascular maculopathy and subretinal scarring. So in this case, the macular deposits are being formed and it can lead to neovascular maculopathy or subretinal scarring. Grade 3 is characterized by the coloboma-like atrophic macular lesions associated with variable impairment of the visual acuity. So there is a atrophic macular lesions like in coloboma. So let's see figure 15.30, which is a North Carolina macular dystrophy. A is showing us a peripheral fleck, B is showing confluent macular flecks. So this is a macular fleck in the fovea. C is showing early neovascular maculopathy, and this is a coloboma like macular lesion. Next is a familial dominant drusen. Familial dominant drusens or duvenae, honeycomb choroiditis, Melascia leventinus is thought to represent an early onset variant of age-related macular degeneration. So basically, it is related to age-related macular degeneration, but early onset. Inheritance is autosomal dominant with variable expressivity mutation in the gene EFEMP1 is responsible. Asymptomatic yellow-white elongated radially oriented drusens develop in the second decade. So in the second decade, there is a formation of drusens. They may involve the disc margin and extend nasal to the disc. So it can also involve the disc margin as well. With age, the lesion become increasingly dense and acquire a honeycomb pattern. Visual symptoms may occur in the fourth to fifth decades. Due to RPE degeneration, geographic atrophy, or occasionally CNV, the ERG is normal but EOG is subnormal in many patients with advanced disease. So ERG is usually normal, EOG is subnormal in many patients. So let's see figure 15.31 is showing us a familial dominant drusens. A is showing typical radially oriented lesion extending nasal to the disc. So this is showing us a dominant drusens, and FB is showing high density drusens with RPE degeneration. Next is the source by pseudo-inflammatory disorder dystrophy. Source by pseudo-inflammatory hereditary hemorrhagic macular dystrophy is a rare disorder that results in bilateral visual loss, typically in late middle age. Inheritance is autosomal dominant with full penetrance but variable expressivity, allelic variation in the gene. TIMP3 a gene is responsible. Early presentation may be in third decade with nectalopia. So most of the time it is basically a result in bilateral visual loss in a middle-aged adult, and there is a hemorrhagic macular dystrophy, and there is an inheritance is autosomal dominant, and TIMP3 gene is responsible, and third decade patient present with the night blindness. When confluent, yellow-white drusens like deposit may be seen along the arcade nasal to the disc and in the mid-periphery. So drusens can be present along the arcades nasal to the disc and mid-periphery, or in the fifth decade with sudden visual loss due to exudative maculopathy secondary to CNV and subretinal scarring. So when it present in fifth decade, it will be sudden visual loss due to the CNV formation and subretinal scarring. When early onset drusens are associated with CNV in young adulthood, this diagnosis should be considered. Peripheral chorioretinal atrophy may occur by the seventh decade and result in loss of ambulatory vision. The ERG is initially normal but may be subnormal in later disease. So let's see figure 15.32. So this is a source by pseudo-inflammatory macular dystrophy. A is showing us a confluent fleck nasal to the disc. B is showing exudative maculopathy, and C is showing scarring in the end-stage disease. Next is a concentric annular macular dystrophy. The prognosis is good in the majority of the cases of benign concentric annular macular dystrophy, an autosomal dominant disorder. So it is an autosomal dominant disorder, although a minority may develop a progressive loss of acuity and nectalopia. So it result in progressive loss of visual acuity, and there will be the night blindness. So this is associated with bullseye maculopathy. It is one of the disease that is associated with bullseye maculopathy. Presentation is in adult life with mild impairment of central vision. Bullseye maculopathy is associated with slight vascular attenuation but a normal disc. A paracentral ring scotoma is present on a visual field testing. So on a visual field test, there is a paracentral ring scotoma. FA show an annular RPE window defect. So this is a central concentric annular macular dystrophy. Then there is a central areolar choroidal dystrophy. Central areolar choroidal dystrophy, also known termed as a central choroidal sclerosis, is genetically heterogeneous. Type 1 to 3 are described but typically autosomal dominant condition presenting in the third or fourth decade with gradual impairment of the central vision. So usually it presents in third or fourth decade and there is a impairment of a central vision. Non-specific foveal granularity progresses to well-circumscribed RP atrophy and loss of cariocapillaries and subsequently slowly expanding geographic atrophy with prominence of a large choroidal vessels. The prognosis is poor. So there will be the non-specific granularity which will be due to RP atrophy, and there is a loss of choriocapillaries which will expand to the geographical atrophy and prominence of the choroidal vessels, and prognosis is poor. So let's see figure 15.33. It is showing us a progression of a central areolar choroidal dystrophy. A is showing us an early stage, B is showing us an intermediate, and C is showing an end stage disease. Then there is a dominant cystoid macular edema. Bilateral cystoid macular edema, autosomal dominant, commonly present in adolescents with gradual impairment of a central vision. Treatment is ineffective and geographic atrophy is inevitably ensues. So it is an autosomal dominant condition in which there is a bilateral cystoid macular edema and no treatment is being effective in these cases. Then there is a Jorger-Larson syndrome. Jorger-Larson syndrome, autosomal recessive, is a neurocutaneous disorder secondary to the defective enzyme fatty aldehyde dehydrogenase activity and is characterized by the congenital ichthyosis and neurological problem. So it is a phacomatosis, which is basically a neurocutaneous disorder, and there is a deficiency of enzyme fatty aldehyde dehydrogenase FAD, and it result in a congenital ichthyosis and neurological problem. Presentation is with photophobia and poor vision and glistening yellow-white crystalline deposit develop at the macula, appearing during the first 2 years of life. Visual evoked potential testing is abnormal. Pigmentary retinopathy, 50% cataract, colobomatous macrophthalmos may also occur. So there can be pigmentary retinopathy, cataract formation, and colobomatous microphthalmos may also occur. So let's see figure 15.324 is showing us some macular crystals in Sjogren-Larson syndrome. Then there is a familial internal limiting limiting membrane dystrophy. Presentation of this autosomal dominant condition may be in middle age with reduced central vision. A glistening interretinal surface is evident at the posterior pole. The prognosis is poor. So at the inner retinal surface there is a glistening of appearance and prognosis is poor. So 15.35 is showing us a familial internal limiting membrane dystrophy. So there is a glistening of the posterior pole. Maternally inherited diabetes and deafness, which is MID disease. The maternally inherited diabetes and deafness constitute 1% of all cases of diabetes with inheritance via mitochondrial DNA. A majority of the patients develop progressive dystrophic macular changes, but vision is not usually affected. Some patients have other ocular features such as pigmentary retinopathy and ptosis. So this is the macular changes in the maternally inherited diabetes. So that's it for the part 5. See you in the next lecture.